Good afternoon and welcome to the public hearing of the Public Accounts Committee. Today, Wednesday, 21st of May, and this is quarterly public hearing with the Chief Executive of the Government of Jersey. We can begin with our introductions. Deputy Gardiner, Chair of the Public Accounts Committee.
Deputy Christina Moore, Vice Chair.
Fiji Kikria, lay member.
Ali Yawan, lay member.
Deputy Raluca Kovac, member of the committee.
Deputy David Wall, member.
Glenn Kehoe, lay member.
Philip Taylor, lay member.
Helen Thompson, Deputy CNAG, representing Lynn as the CNAG.
And attendance. And yes,
Andrew
please.
McLaughlin, Chief Executive Officer.
Tom Walker, Chief Officer for Health and Care Jersey.
Sebastian Perez, Head of Corporate Governance, Treasury, Exchequer.
Yeah, and thank you for your time. And we would have 2 hours and we have number of questions to get through. So please, I could ask to keep your answers short. And I apologize in advance if I will interrupt in the middle because we really tried to get through the answers. What I will not be able to ask, not have time to ask, will continue in writing. Today, we would look into 3 areas. The first one is annual reports and accounts that were recently published of 2024. Second area is arm's length bodies, questions are based on CNAG report and how the recommendations were or were not implemented. And the third part is deployment of staff resources at Health and Communities, Health and Care Jersey. Which was again CNAG report, and we'll look into the implementation. We'll start with annual reports and accounts, and now we'll have to Deputy Kovac.
Thank you.
So looking at the public annual report and accounts, public awareness and recommendations from last year, can you confirm what steps you have taken to publicize the presentation of the annual report and accounts this year and what was different than last?
Sure. I mean, I think thank you for the question. We obviously had a recommendation that we could and maybe should do more, which was picked up by the comms team and then discussed with myself and with the Chief Minister and Treasury Minister. Following that, we repeated everything we'd done the previous year. But the conclusion of that discussion is that we could do more in particular, or at least this year should do more in particular, to raise awareness and engagement through social media and various forms of social media. So following the recommendations of the comms team, that varied from blogs, longer articles and so forth, various things to engage with people. That's what we followed through on, and pleasingly, I think, so far seen a significant pickup year on year in terms of people going to the landing page, downloads and engagement with the content.
And was there any public feedback on awareness or accessibility?
Not that I'm aware of off the top of my head, but I can double check for you on that. But
What specific channels have been used and how do you measure that was efficiently?
yeah, so I think we're using all of our existing social media channels, obviously our web page as well. So we haven't introduced new channels, if that was the question. It's more the use of existing channels. And the measurement is using the normal data that we measure around social media in terms of visits, in terms of people landing onto the page, downloading material if it's downloadable, and engaging in that way. So, and we feed back to, or if you take myself as an example in terms of the social media content I was asked to do, we get feedback from the team on views and so forth and how that compares to the previous year. If it's something that we can compare accurately with the previous year.
And have you seen increase in views?
Yes, we have. We've seen increases on all those things year on year, and I can happily get those stats sent along to the committee afterwards if you would like from the comms
Yes,
team.
please. Thank you. Regarding the recommendation to can you please provide evidence that ministerial briefings have taken place across all departments, reports for the respective minister ahead of publishing the report?
Yes, this was a recommendation that officials should do this with ministers. I mean, I'm not sure what the committee would like by way of evidence, but I can give the assurance that all chief officers were asked to do that, and having done it, to come back and confirm that they've done it, they'd had those discussions or briefings with their minister. So again, I'm pleased to say that certainly all of the ELT have confirmed that back to me, that that those briefings have taken place.
And were there any changes or adaptation of the report based on the ministerial feedback after the briefings?
Well, that I couldn't tell you for all colleagues, but I'm happy to come back.
Not just the health side, and so that it was more balanced across health and care. So that was one of the adjustments that we made.
Okay, perfect. Thank you. On recommendation 3, we note that staff reporting has returned to employee numbers rather than percentages, which was a recommendation of the PAC in its review of 2023 annual report, and was rejected at that time. While this is all welcome, can you please confirm why this was rejected in the first place, and is that something that's going to remain permanently implemented?
Are you referring to the table we've now published in page 136 of the accounts? I think the intention is that that's now a permanent feature.
Okay, yeah.
Yeah.
I think so, yeah.
Where we
Yeah.
have the number of employees rather than the percentage.
Yeah, exactly. So I think the intention is that that is a permanent feature.
Great, that's welcome. And why has there been no reporting of cost pay by bracket as in previous year?
No reporting. You mean of
By pay bracket?
numerical amount rather than of?
So you have the numbers of employees and
I mean the
percentage.
cost expressed in pounds on each
Per
bracket.
pay bracket, yes, per each bracket.
I guess I speak for myself here. I'm just trying to figure out the meaningfulness of it in terms, because it will just reflect inflation each year in each pay bracket, will it not? If I'm thinking of the same thing.
I'm thinking about the CB report that was in 2022, and it was moved into the accounts, that it was very clear that these pay grades, we have X number of employees, that pay grade, we have other numbers. So it was very clear, it's not about just the number, it's about the pay grades, because the number obviously replaces the pay grades, and it's in public domain. So it's in public domain how each pay bracket paid. So what we're talking about at previous reports before 2023 counts, we had clarity how many employees within this pay grade.
I thought that's what we'd given you in page.
Maybe we missed it.
136.
Which
Numbers,
page?
yes, but not the bracket.
Which page?
136, we give you the pay grade group, and we tell you how many roll holders are
136.
in each group.
136.
Page 136.
One second. Okay.
I don't have it in front of me.
Is this? No, I think it's good, but we'll compare this to the table that we're talking about, because I think it was bigger table, but maybe you present it in different. We'll come back to this. Thank you very much
And
for
my
pointing it.
apologies. I don't,
No worries.
the,
Okay.
Okay,
Yeah.
the next.
The group accounts show a deficit of 93 million, of which the core entities are 99 million. It's the deficit. Not many people in the island will have read all this. They may not have taken much notice of things that have been said. I wonder if you could give a very simple explanation as to what the cause of that deficit is.
Okay, this is a deficit, of course, before surpluses are added back in.
Yeah.
Just to reassure islanders that this is a group deficit. Really, in the simplest terms, it's got two main contributory factors. One is a deficit in the consolidated fund.
Yeah.
The consolidated fund is probably best thought of as the current account of the government. And the second main contributory factor to it is revenue that the government spends on projects which, under its current account, under the accounting rules and its current treatment of it, can't be capitalised. Probably the best example I could think to try and answer your question for simplicity is in spend on cyber. So cyber spend is something that's going up everywhere. It's obviously topical in the news. Much of that spend can't be, in accounting terms, capitalised as capital projects. So it would appear in here. So hopefully that answers your question. Those are the two big drivers of it.
And was that anticipated?
The part of, well, all of it was anticipated, but if you go back to the beginning, definitely within the consolidated fund in particular, I'm sure we'll come on to it, there is a significant factor in there is health spending. And outside of health spending, most of the other stuff I think you would regard as routine or regular or likely to occur, the sort of thing that can happen. The one thing that's different is that big number, which I think has been well trailed elsewhere, of 28 million inside the consolidated fund related to health. But the other stuff like cyber and so forth, you know, I think given what's been happening in the world, it was something we could have expected.
Can you remind me what additional steps were taken during 2024 to address the increasing shortfall, should we say, on the health spend?
Sure. Do you mean the steps to try and mitigate, or the steps that were taken to make sure it could be funded?
That it was kept within bounds.
That was the. We're going back now to where are we? The start of last year. So I think the potential overspend in health was called out very early in the year, first quarter of last year. Called out almost immediately, probably when the new health ministerial team came in. The main factors of it, I think we've given some detail of it in the accounts. But I'd say there's a couple of drivers of that deficit, all of which I think, most of which I think are factors that have been with us since COVID and don't look like they're going away. So one of them is our need in various areas to rely on agency staff. And the cost of that, which we've got a very significant supply-demand imbalance around Europe in that area, and we're a price taker. A second factor in there that we had was, in similar vein, increases in drugs cost. And, third factor, very importantly for us, is an increase in what are called tertiary costs, but essentially those are situations where we as an island procure care from off-island, either in health or in children's services. And because I think of some of the pressures that's facing hospital groups, in particular in the UK, they are passing a lot of costs, they're trying to pass a lot of costs on to us and others through those contracts. Those are the three main factors. A factor last year, but probably Tom will correct me, more pronounced this year, is almost what I'd call negative income, by which I mean if we have a difficult winter in terms of bed capacity, a bad flu, literally, then it knocks out capacity that we'd otherwise had allocated for private healthcare treatments, which are income generative for us. So the other factor we've got in there is the loss of income because the beds weren't available for private procedures. But those beds, of course, were being used to deal with what's euphemistically called the winter crisis.
And what was there anything you could do about those problems?
There's a number of things we can do in each of those categories to make the situation within year less bad. So the amount of things you can do within year are probably more limited than you would like. But for example, on tertiary health care, which I would say last year was the most surprising element of the deficit. In other words, we hadn't envisaged seeing such significant price hikes from our suppliers. Maybe we should have, I don't know, but it was a surprise to me. What we had to do there was fairly painstakingly have recourse back to the framework agreements we have in place with NHS. Is it NHS England?
Yeah.
With NHS England, we had a framework agreement in place, which we think afforded us some protection from price movements of that nature or from changes in contract. So we did actually have some recovery in that category. The deficit, dare I say, it could have been worse, where we were able to go back to that, have spent a lot of time with NHS England and with the UK authorities to try and, at least in our view, reduce some of those cost pressures, because we felt under the framework agreement that we were entitled to that. So that was a difficult length of negotiation, which did yield within year. And it's obviously something that is serving us better this year, because we've re-established some ground rules there.
Okay, something you want to add to that, Tom?
Yeah, Tom,
while
you
you're
may
here?
want.
No, we'll. I think we're going to touch upon
You've had a very
tertiary
good,
care
You have
later on.
had
had a very good
So-
full report. Just now putting in big picture stuff. I mean, you've commented, Andrew, and the fiscal policy panel has also commented on the overall financial position of the government in terms of the reserves perhaps not being as big as they should be. And in the face of increasing health expenditure, the situation is not going to get much easier unless something is done about it. And so I'm wondering what sort of advice you've been able to give to ministers in terms of how this fiscal, if this imbalance is going to get corrected so the reserves are increased.
Do you mean specifically relating to health, or just in general? About
general.
In general. So, and this is a reference to the FPP
Yes.
report of last Friday that they put out. Yeah, no, again, thanks for the question. I think on that one, it's quite a sobering report, I think, from the FPP. Not necessarily a surprising one, but a sobering one. Essentially, it translates for me as there are mounting risks in the world economy. They're translating into increased downside risks in Jersey in the form of potentially a forecast for lower growth than they had previously and higher inflation, which is not a great mix, and that therefore a tighter public spending or public finance envelope. They also said two other things which I think are more stark than in previous reports that we need to pay attention to. They've called out a heightened risk, I think, to Jersey's International Financial Centre because of the change in trade policy in the main between nations. It is impacting global capital flows, and it's creating a lot of uncertainty around global capital flows. And Jersey's finance model depends to some extent in some of those capital flows coming here. And they've really called that out as a specific risk. I believe for the first time in response to what's happening, that could impact our future revenues and growth prospects. And then the final thing that they call out very precisely is partly again related to changing policy stances in bigger nations, is the uncertainty that now surrounds the OECD Pillar 2 tax regime and what that might mean in terms of potential tax revenues for Jersey in particular. So you put all that together, it's very sobering. And really what they're saying is the world is a riskier place. The risks to growth have increased. The risks in particular to financial services may have increased. It's unclear. You only really have three things you can do with your money, Jersey. You can save it to reserves. You can spend it on capital and hope that it gives you productivity in the long run, or you can spend it on services. And really they are advising that because the world's riskier, that we pay more attention to saving to reserves and to a lesser extent capital over spending on services. Our advice, I think, to ministers around this, but predating this, has been very clear, which is trying to urge prudentialism. I think a more prudent approach to public spending, a more prudent approach to the public finances, and a more prudent approach given the risks and the uncertainty around those risks in the world economy. And that's why I guess you see various efforts to try and begin curbing public spending growth, or at least to start having discourse about the need to do that.
Yeah, okay. Thank you.
Have any fiscal policy panel recommendation have started to be already implemented?
Well, this particular report, I mean, I think we'll be waiting for the summer for their fuller report. But what they've given us here, of course, is a revised or a forecast, but it's a revised forecast. That forecast now is the trigger for feeding into the budget round and the series of workshops we'll have around the budget and setting the budget. So a lot of what they're doing with this work is, if you like, marking our card before we go into the budget round and the budget workshops. I think any additional recommendations will come with the report later in the year.
Just for my clarity, you used word, and I completely agree with you, prudent
Yes.
approach. Now, obviously, all of us has different understanding. What does it mean, prudent? When would your advice be around this? What does it mean? If you can give me an examples in practice, that practical examples that the public can understand, what would be your prudent
Exactly.
recommendation?
It's a great, you put me on it today with simple and practical.
I want to be practical. I want to understand what does it mean
Especially
in
when it comes
practice.
to accounting and economics, but I'll give it my very best shot. So to use this, what does prudentialism mean in the context of their report last week?
What about your recommendations? You said your recommendation to the Council of Ministers.
So, for example, one of the FPP recommendations from, I'm going to say summer of 24, was to find a path through successive budgets to restore the relationship between our general reserve and the size of our economy. In other words, as our economy has grown over the past 30 years, there haven't been net contributions to the general reserve along with that growth. Our general reserve was essentially established out of windfall banking profits in the late 80s, and it's kind of grown with investment returns ever since. So one of the things that they recommended is that you find a way, despite it being a very tight situation with public finances, to start meaningfully contributing each year to the restoration of the reserve, or to try and restore that relationship between the size of your general reserve and the size of your economy. And essentially that's advice that we think is sound and that we need to try and find a way to follow. You could say the same thing about restoring the stabilisation fund. Clearly during COVID, islanders will know that our resilience was tested. We used a lot of the reserves that you build up for rainy days for that rainy day. We have specific reserves to deal with times when the economy goes through 2 or 3 very difficult years, counter-cyclical reserves. We've used those reserves. I think everyone would agree that it made a huge difference to the island getting through COVID with far less disruption than might otherwise have been the case. But we're now through COVID. And even though it's a very difficult and risky world, our advice is to keep looking to be prudent, to try and build up the reserves. Because I think the thing you can say really since the whole era of ministerial government has been one shock after another, starting with the financial crisis in 2007. Almost every 2 years there's either been an economic shock, a geopolitical shock, or in the case of the pandemic, a health-related shock. It's been one thing after another. So I think the days when we thought we might get 10 years of not much happening seem to be over. And that's why we're urging prudentialism.
Okay, thank you.
Thank you. So we've noted that there's like a 63 million deficit on the operating deficit of 63 million. Can you just explain what are the main drivers behind it? And specifically just looking into the depreciation number, there is a variance of 16 million, which is not forecasted or budgeted. What that would come through that number, and taking from there, what are our cost saving plans now, and are we expected to just go in the same way?
Thank you for the question. I think that there are, again, two big things in there. one of which we've already mentioned, so I won't go there again, which is the 28 million in health. On depreciation, although that would seem a big number this year, it's not a number I would worry about in the same way. In other words, it's the sort of thing that can happen. So big factors behind that depreciation is you always have uncertainty over the timing of when projects complete. You have uncertainty over the timing of when assets are disposed of, both of which can give rise to charges. So I think in the year that we're talking about, for example, you will have a charge on the asset disposal of Overdale, or the write-down of that asset when it was demolished, the hospital asset. The timing of, even though we always knew it was going to happen, the timing of it a little unclear. We had the same thing, dare I say, with sewage treatment works and other assets. So some of this is about timing. Therefore, it shouldn't repeat, if you see what I mean. It might have been brought forward, it might have been pushed back. And the same is true of various IT assets, which attracted charges. So that part of the 63 million, I'm less concerned about because it's accounting and timing. Obviously, health we are concerned about, as I'm sure we'll come on to discuss, or we've discussed before, but we will definitely discuss again. Does that answer your question?
Part of it definitely. And just from the accounting point of view, if the asset is being written off, wouldn't that form part of the impairment line item, not the depreciation? And similarly, taking on the other things, as you mentioned, it's not part of our budget or our plan. So if we are anticipating something, that should reflect the budget as well, which wouldn't be very surprising to see a 16 million charge. So why we are missing that in the forecasting if we know that Overdale is going away or something like that?
Again, I'm not sure, and it's probably a better question for the Treasurer to go into the detail on. I'm not sure there's a whole jumble of assets in there, some of which I've mentioned, others of which I haven't, around various aspects of our property estate being revalued downwards. I'm not sure that it's highly irregular. It's just unfortunate that you had a number of them at once, is what I would say. But I definitely pursue the county treatment of it in more detail with the Treasurer, because I think you've got them in a few weeks.
Yeah, we'll have Treasurer and Tom coming back to us
Yeah,
again in a couple of weeks.
Sorry.
But what's for me, Andrew, there's two things to pick up. One, for example, demolition Overdale, I think it was planned for 2024, unless I remember something different. So I'm not sure if demolition of the Overdale would reflect this, but maybe. It's about the forecasting. We're not talking about numbers if you worry or no worry.
Yeah.
It's about how good is the forecasting, because depreciation, it's one of the things. It's not like tertiary care that going up in the UK. It needs to be pretty kind of more or less around it, maybe some. So we asked Treasurer, just question was around, I think, forecasting that in general terms. But we'll follow it up.
Yeah, I'd follow up with it, definitely.
Just to take from there, I think the accounting treatment from disposing assets and loss on assets is different from depreciation. So that's why it comes up to a big number and it's surprising or unexpected. But we might need to go a bit deeper in that one. Just moving on from the overspend point of view, within the process, are there any consequences or they take on overspend specifically to the officers who are overspending? Do they get reviewed, and how do you look after their performance and follow-ups after that? What's the process through this?
Sure. So I think there's probably two parts to that. Are there consequences, and what do you do when it starts to happen at the process? Particularly my role, I guess, in that process. So I think it's effectively illegal under our public finance law for you to overspend. Tom. So as part of your legal obligations not to overspend, historically where there's been a risk of spending, and particularly where that spending is deemed to be justifiable, it's, as I understand the model historically, the Treasury team or the Treasury Minister has resolved that with recourse to reserves or changing heads of expenditure, so that they found a way to restore balance, and that's the process. So to some extent it's illegal. You can't really commit to spending if you don't have the budget, but I think it's fair to say the custom and practice is there's always been found a way to manage that situation where it occurs. Where that situation, I think, is much more pressing going forward is that we do not have the reserves readily to hand to manage those situations where one budget, for whatever reason, or a couple of budgets get out of whack. So in the past, there's always consequences, but there's always been found a way to manage it. In terms of how I've been approaching it, particularly as, sorry, Tom, I keep looking to you, but particularly as health has been my first sort of experience of this on my watch. If essentially we go through 5 steps, some of which I hope will be put into the public finance manual, or at least that is the proposal from the Treasurer and the Treasury Minister to update the finance manual. But there's really 5 steps, which I'm happy to go through if you wish very quickly. But
I think the question is is there any performance-based follow-up, retraining, sanctions subject to review? How does it affect the performance management?
That's my answer. We've got a process we go through with 5 steps, which I can explain to you very, very quickly. Obviously, the first of them is reporting, is the timeliness of reporting to alert us to the fact that there's a problem. The Treasurer can talk about that at length, but a lot of work's gone into trying to get information to the top tables quicker, so that if something does occur, you're not 3 months down the road and already you're chasing a bus that you might not be able to catch. So trying to improve reporting, that was a big feature, trying to get better information quickly within health, for example, which the previous government spent a lot of time with in the financial recovery work in health. So early reporting. Essentially, we've got a trigger. If it's a small amount, less than 1%, and it's readily explicable by the senior officer, because the odd thing can happen, timing or whatever, it's less of a concern. If you can see already it's building towards 2-3, really 3% is a trigger to say this could be a big number, and it is a deeper dive. The second thing, the next step after the trigger is the diagnostic. The Treasury team go in. If it's already clear what the issue is, if it's a headcount issue, or if it's a IT issue, then more than just the Treasury team might go in, work with the department to do the diagnostic and get clarity on what the remediation plan effectively is. So that the next stage is the department saying we can remediate this within our own budget. They have to replan, bring that budget to me and to the Treasurer for approval. If we find ourselves in a situation, step 4, that says because of the diagnostic, number 1, might not be resolvable within a year, and it might not be resolvable by that department alone. It's going to have an impact on the wider budget or on other departments. In that situation, quite often, we are looking at something that might be more structural than. It might be deeply cyclical, or it might be structural rather than just a timing thing. In those instances where we think it's structural, then it has to be elevated up, which is the penultimate step, to the Treasury table and the COM table, because it could affect everyone at that point. And I think health, without wishing to preempt the debate I know you're all going to have about health later in the year in the Assembly, or indeed what the Minister may have said yesterday, which I'm not appraised of, but health is an example where I think it's legitimate to say there may be structural issues here which require a structural response rather than an in-year tactical response. Where that happens, it has to come up to the top table and be debated out and resolved out, because then it's no longer heads of expenditure within department, it's no longer moving things around. It's much more about reprioritisation at a government level.
uh,
So that's how we work.
But it's very much known that this isn't a year-on-year issue. I think the turnaround team identified when they first arrived, which is in Christmas 2022, they identified that there was an issue with the control of expenditure in the department, and steps were taken to bring that under control, but clearly it hasn't been fully achieved yet. So what is being done to rectify and bring under control that expenditure?
So in that instance, it's a complicated picture in health, as you know. So that turnaround team targeted a number of areas of control within their financial recovery plan, and that yielded, from memory, about £9 million of savings last year. So the things that they were controlling and where they put controls on, which I guess, not having been there, were the things they diagnosed in 21 as the things that, or 22, that had to be controlled. They had some measure of success there. Those were around areas of procurement. Those were around areas of staffing levels in particular in some areas. Where they did not have probably the same amount of focus in terms of recovery plans were in areas like tertiary contracts and the extent to which we would see this surge in inflation from our suppliers in the UK. Now, of course, as I explained earlier in answer to Philip's question, action was taken in that area. So I think my point in health is that they focused on a number of things and had some effect. The bigger drivers look like the ones I mentioned earlier, and they look like not a short-term reaction to COVID, which disrupted that healthcare market significantly. They look like persistent things that aren't going to go away, and therefore they require a strategic response, not a control response, a strategic response.
Can I just ask a broader question?
Yeah.
And you've sort of kind of referenced this a bit. And that obviously this overspend has wider implications if it's structural, in terms of, obviously we've seen education being reported as being in having deficit situation. We've got underfunding in infrastructure, serious implications there. Basically, you've got health, which is absorbing so much of the island's finances at the moment, to the detriment of other major spending areas. So if you can't sort out health in terms of the structural deficit and this major problem, what are the implications? Is this about rising tax base to islanders? How do you fund any of this in the end? I mean, or do we just see declining education services? Do we just see decline in education infrastructure? Do we declining? You know, where do you give? Where's the give? If we want to carry on spending in education, spending in infrastructure, and we just don't have the money, and you don't have the reserve, what's the solution?
Well, going back to health, obviously it was able to be resolved last year because it was called out early, and it was able to be funded, or the Treasury was able to fund it in the normal way that I mentioned that they've done historically when they've found areas of overspending. I guess what I'm pointing out is in resolving that last year, and given where we are with reserves post-COVID, our ability to keep resolving things like this is
I understand. I understand that.
So that's why I think health in particular, and to be fair to the Minister understands fully that given what's happening in healthcare, and given, we are a price taker in healthcare, we're not a market maker. Given what's happening in healthcare, given the balance that has to be struck between the services that islanders would like to receive and the affordability of those in this healthcare market, this has to come to the Assembly in terms of what is the future model for health, and what are the choices therein for the funding of that future model. Is it a reprioritisation?
Okay. So
or is it something else? And I think that's properly a matter for the Assembly and the politicians when it comes. As officers, we'll give our best advice on the options and the way through, as I explained last time to the panel.
But this has major consequences on lots of other areas.
Yeah, look, I mean, I think we had a discussion before about the 5 historic policy choices Jersey has made, which it lives with every day. I think what it decides to do in health will be seen as its 6th historic policy choice. It's as big as its choice on tax and spend. It's as big as its choice on the carbon neutral roadmap. It's as big as its choice on building and immigration controls. It's in that bracket. And this is the year, this is the winter where you're going to decide it as an assembly.
Just last very small question. On all of this comes down to the people, like the people who are managing this.
Yes.
How does their performance reflect if they are going and overspending each year?
Yes, so in their objectives, if you're talking about the individual
Personnel,
officers, as part of their objectives and part of the weighting of their objectives is financial control and their ability to make their budget.
Yeah.
And I do want to put this in context. Of course, you've mentioned, I think, 3 departments who have found difficulties. They found a way, but they found difficulties managing their budget in the current environment. Set against that, of course, we've got 6 or 7 who have met their budget. So it's not a uniform situation. There's pressure in 1 or 2 areas.
But how does that reflect on those people? Because in normal course, we'll see and identify if there's somebody who's not able to manage something.
Yeah, so in a number of ways, we have a low performance rating. In the most basic sense, if you've not been able to meet your budget and we felt that you could have. If we think that's a development issue, that one of the reasons you're not meeting your budget is because of capability rather than motivation, then there'll be training and development and there'll be additional support, particularly from the Treasury team, particularly from the finance business partner. So those are the sorts of normal steps you'd expect us to take.
I'm listening to this conversation and I will share my reflection, and I would like to know under your thoughts. If we're looking into the net revenue expenditure in 2024, it has increased by 177 million. I know that within its social security grant that was introduced, 77, we still see expenditure rise by 9.8, which is above inflation. What I'm trying to, if I'm looking around it was reported that 30 million was spent more than projection of the government plan 2024. If I'm looking to 2023, the annual reports and accounts show that 30 million overall was spent less than projected government plan. So somehow in 2023, the books was balanced in a different way that this. Now, my question is, even if we're looking at the health overspent annually approximately 30 million. So in 2024, they were allocated extra 30 million on top of their budget. They overspent 30 million. You said that already in the Q1 2024, you expected that it will be overspent in health. How the Q1 2025 looks like? Do you expect overspent in 2025 for Q1? Do you have projected optional overspend?
Yeah, so 2024, obviously, that's numbers we're talking about. I don't think I mentioned yet.
No, you didn't. I said that. I'm at my question.
This year, but certainly some of the trends, or some of those drivers, of pressure on the health budget in 24. I can answer the 23 question if you want that you raised, but in 24, I think some of those trends are persistent, maybe not at the same level of intensity in some cases, but the persistence of that issue. For example, we had another winter where the pressure on beds in the middle of the winter knocked out capacity from that we had allocated for private healthcare treatments. Therefore, you get a delay.
Also in 2025.
Yeah, exactly. This winter that's just passed, which leads into 25. So that pressure's there again.
But in this question, my question, so by Q1 2024, you had projected overspent, and obviously by the end of 24, we saw projected overspent. Now we are beyond Q1 2025, and we hear the same kind of difficulties, challenges that health's experiencing. So what are the issues maybe we have with actual forecasting model? And how do you intend to improve it? Because it sounds it's the same story coming back annually. So if you knew that 24 has happened, why it wasn't forecast for 2025?
Oh, yeah, see, I've got your question. Well, of course, we're in the midst of that. We're in the midst of that now. Some of those trends, I think, by their very nature, are difficult to resolve within a 12-month period. So I think you're in the area there of trying to reduce their impact or reduce the scale of them. So again, the example that I discussed with Philip of trying to reach a better accommodation with NHS England on how we will be treated under the framework agreement from the 30 or so, is it 30 different contracts you've probably got?
Only 50.
50, sorry, you see my 30 and raised it to 50. So we've historically got 50 contracts into various hospital providers in England. The clarity, seeking clarity under the framework agreement and enforceability, we hope will reduce that pressure. It won't reduce it to zero, but we hope that it will reduce it. So, yeah, we're taking steps to mitigate it, but I think it's a fair point. Some of what we're dealing is difficult to forecast. It's difficult to forecast.
But number
some
of
these
beds
things.
during the winter, it feels like it's coming year after year, and this overspend coming in. So for me, we'll look into more with the treasurer around the forecasting and the model of the forecasting. I think this is just the
Yes, and
question
I think
to consider.
you'd always expect me to say that you shouldn't judge a forecast by its accuracy alone, as economists say. And I think when it
Fair
comes to
enough.
health, that's definitely the case.
Before we move on, you said that you'd be able to offer your response in terms of the difference between the management of the situation in 2023 versus 2024, when there was the Q1 view that there was going to be an overspend in both scenarios. Could you elaborate?
Sure, and what I was referring to there wasn't, forgive me if I've got this wrong, Deputy Gardner, but I thought you were contrasting the situation where we generated a 30 million surplus in 2023, which we then allocated to reserves, versus a situation in 2024 where effectively reserves were used for
To meet
partly
30
used
million.
for the health budget. So in 2023, if you recall, and you know, with respect, both of you were there and part of it, but we did a deep dive into, at that time, the way we were approaching capital projects and capital spend, and we concluded that while we had fairly significant budgets for capital spend, the actual cash wasn't aligned with our ability to deliver them in terms of having the resources, the people and so forth. And when we had a deep dive into that whole area, we concluded that there was around 30 to 40 million that just wasn't likely to be spent and should be available to reserves. So that was the exercise we went through in 23, which created that opportunity.
But it was an exercise, and we'll go back to the capital later.
Yes.
Yeah, it's capital is different.
And as the chair mentioned, the department net revenue expenditure increased by 177 million in 24. Which departments had the biggest spending increase, and were all this overspending forecasted or unplanned?
We'll leave to one side the second biggest factor, which was the restoration of the state grant, because I think everyone knows that was the biggest factor in that was the 84 million allocation for the pay award. And if you then look at that by departments, I'll have to come back to you in writing, but I'd imagine that health and education were the biggest beneficiaries of that 84 million. That plus the state's grant obviously is the bulk of it. The bit that's remaining is the approved growth from the plan, and probably a good example of that smaller category of approved growth is the Deputy Lewis amendment on agriculture and fishing, where the Assembly asked us to allocate additional monies to those sectors. Can't remember off the top of my head if it was 5 million, but it was an appreciable amount. So we had approved growth, which included additional staff to support the Schools Meal programme, but we also had amendments which had to be funded. So, but that third category was the smallest. You had 77 from the state's grant, 84 from health, and then the remainder was that various bits and pieces under
Not health,
growth.
from the pay award.
84 from the pay award,
Yeah.
77 from the state's grant, and then the remainder is just what I'd call approved growth, but it also includes
Yeah,
amendments that we have to fund.
And talking about the staff that you mentioned, staff costs totaled 659 million in 2024, an increase of 30% than the previous year. Have these increased costs been frontline services, and can you provide evidence of where increased costs in terms of staffing have come from?
Sure. So just for clarity, this is the total staff cost bill is 13% higher, 24 over 23. 8% of it is the pay award that we just mentioned. And then we excluded, essentially 3 areas were excluded from the recruitment freeze: health, education and non-mins, what we call non-mins. The growth, the net growth in jobs, therefore the other 4.5% that gets you to 13 is from those 3 departments.
Health,
and the
education
biggest,
and-
health, education, non-mins. And the biggest, did you ask what the biggest beneficiary was? I think the biggest beneficiary in there would have been health and education again.
And in these departments,
Frontline roles.
in these departments in particular, is there a measurable link between staff cost increases and improved services?
It's a bit early to say because we're just talking about jobs added last year and pay increases last year. Obviously, I think the Education Minister, if he was here, would say that to the extent that people regard the provision of a healthy meal in all non-fee paying schools as a new and enhanced service, then I think the colleagues that we recruited to make sure that we could deliver that service, people would see that as an improvement. I think in other areas, health and so forth, a great deal of what we were doing, frankly, was trying to, and nursing's an example, Tom, is trying to replace agency staff with permanent staff, where we've had quite a bit of success. I think it'll take us a while. It'll be multi-year to demonstrate an improvement in service, by which I mean, obviously there was a nurse there before, and now there's a nurse who's on a permanent contract, and hopefully as a nexus to residency in the island and settling the island versus agency. We hope that will give us stability in terms of turnover over time. We hope it will give us service improvement levels over time, but sort of 6 months in, I think it's a bit too early to call that.
Thank you. Staying to the breakdown of the net revenue expenditure, on the same chart, we have 338 million outlined as other expenditure. Can you please provide the breakdown of what this relates to, and this is the one-off or recurring expense?
Yeah, so this is, yes, the things you learn when you have to go through the accounts. That's what I'd say about this. This is a bucket for things that don't fit into our, I guess, our normal or our historic categories, be that staff, benefits, grants, or whatever. So it's something that defies the current budget classifications, which we probably need to look at because it's quite a big number. But it includes, for example, things we've discussed already. 2 of its biggest items are the purchase of tertiary care by both HCJ, but also by Children's Services, when we purchase off-island care or where we send patients or children off-island for whatever reason, that those expenditures fall into this bucket. Another good example I would give, there's 4 or 5, but these are 2 of the big ones, are legal and admin costs, but they're primarily legal costs and insurance costs in particular, which we incur. And I think one of the things we have to think about as an island is we are under pressure on insurance costs because we've had a lot of hits to our resiliency in recent years. Some of the major incidents that we've had, some of the things that have happened, inevitably in the insurance market attract scrutiny about the premiums that you pay. particularly where government is not self-insuring and has big risks that it thinks it ought to insure. So those are two of the biggest ones. What I'd want to reassure you on, you can probably tell from both of them, these are not areas that we just say, well, they're in that bucket, we can't do anything about them. One of the objectives of the Treasury team this year is to look at the top 4 in there and subject them to intense scrutiny. So we had intense scrutiny on our insurance costs in the period past. We've obviously got very intense scrutiny on the tertiary care costs, as I mentioned, with NHS England.
And how do you make sure these costs are being properly tracked and justified? And to increase transparency, could it be more itemized, clearly itemized for the public as well?
The other biggest number, I've mentioned the two biggest numbers. The third biggest number is drugs. So it's purchase of drugs and other medical equipment. So I think it's important to realise that these are costs that are embedded in core services that we purchase. It's just that for whatever reason, the way that we do our budgets, they fall into this bucket rather than into some of the other buckets. So I think that to reassure the public, this is all spending on things that they would recognise as things that they consume, that the island consumes, or their investments in areas that are vital to the resiliency of the island, like aspects of technology and telecoms, where we've had to make a lot of changes because of the change in geopolitical situation over recent times.
But even in just very brief, it could be clearly itemized, at least to know what that category
Or itemise the individual items. Yeah, I'll definitely take that offline. Some of them I think are...
If they're bigger numbers, it's 336, others, it's big, it's a big number.
I think
At least the
buckets
biggest
we can-
items, yes.
Yeah, no, I think we can do that. I don't see any reason why not.
Like
Again, double check with the treasurer, but we know what they are, to reassure you. We know what they are.
Accounting wise, normally like legal costs are shown separately just to see if there were any litigations or anything. So these kind of
Yeah,
items,
no, I think that's fair.
Yeah,
I think that's
like
fair.
insurance costs.
Okay, next question. Hopefully a very straightforward one. Can you explain the reason for the 67% increase in social benefit payments during 2024?
It was the reintroduction of the state grant.
No, but not just this, I think. It wasn't just, it was also social benefit. It's 39 million increase without introduction of the,
Yeah, I think those are volume driven. In other words, they're demand driven. They're up at 7.5%. So I think that's...
we have two tables. There's one including introduction of the state's grant, and another it's...
It's still 8% increase, yes.
Yeah, 7.5%. Yeah, that's... I'm afraid that's life. That's just volume.
But we
People
have
needing
less
support.
unemployment, so just to understand what's important for
that's
us
a
to
good-
understand is
Yeah.
are the trends, what were the reasons, and if it's anything can be done to reduce, or this is what we'll see year into year, kind of what's happening this time.
Yeah, no, sorry, I understand the point now. It's a great point because obviously in Jersey you shouldn't equate unemployment with benefits. The business model that we're trying to run is one that requires full employment because that's how we get tax revenues. So we've got a lot of people who are in work who still need support to be in work in order for them to be able to earn their keep and run their life in Jersey. So there's quite a lot of in-work related benefits or other benefits to support people.
So the question, if the policy changed, so we see increase of the social security benefits and the people receive more, or we have more people coming into the system. So,
Yeah,
huh?
Could it be perhaps the £20 million that was provided to?
No, it's
support-
not here. It's 20 million pounds coming in the council.
I mean, the
2025.
biggest driver of this is, which we've published, is, in fact, the only driver of this, which we've published, the net driver of this is pensions.
Pensions. Okay.
This is not breaking news, but Jersey's got an ageing
Where we're
population.
heading.
Yeah.
Okay,
It's
yeah.
where we're heading.
Thank you.
Yeah.
No,
Those
fine.
pension benefits are the net increase. All others are just going up by demand, not much at all, or
By
down.
demand,
some.
it's-
Yeah.
okay.
Sorry. Yeah.
you.
Apologies. I wasn't sure what. Sorry.
That's fine. Thank you.
Great. So I'm very interested in your views on productivity throughout the government. I'm sure it's something that underpins most of the decision making. However, there's only been one reference to it today so far, where you mentioned productivity in relation to capital spend, although that's clearly not the only driver of productivity. The annual accounts make 5 references to productivity, but it's not quantified anywhere. So we're very interested in your views. I mean, there seems to be a shift in government that the Value for Money programme has been superseded by various savings programmes. And savings isn't necessarily the same as value for money or efficiency, certainly, or productivity. Clearly, when it impacts on frontline services, it could act to its detriment. And I'm sure that islanders will be interested in understanding the extent to which frontline service quality is being maintained. So, with all of that in mind, I've got a series of questions on productivity. The first one being, which specific metrics do you use to distinguish efficiency gains from service quality gains?
Well, at its very simplest level, in terms of efficiency gains, we are trying to get as close to the cost for output per hour worked as we can. Obviously, in all areas, but particularly public service, it's a very crude measure, and it's obviously been a feature of us trying to figure out where, with the recruitment freeze, for example, when it's applied, not to, which it isn't, to a couple of big departments and to other areas of frontline services, where the bias is towards, if we can, preserving frontline services, or at least preserving the people who deliver frontline services just as accurately, versus middle and back office. It's very much been focused there on the cost to provide that service and the FTE, because it's easier to count FTE than anything else in government. So if you look at areas, for example, like the Cabinet Office, that's been a driver there. In terms of service, was the second part of it about service quality? Service quality, correct. In terms of service quality, it varies by department. So if we're looking, for example, at we'll get you off the stump in health for a while, Tom, and look at ESH, and in particular something we just mentioned as social security in that area. Then service quality there it is across a range of qualitative and quantitative measures, everything relating to how quickly we deal with people when they've got a query or when they've got a concern. Waiting times, all of these measures. They include how long it takes us to address an issue. So we have targets in some areas for how long it will take us to resolve an issue, be it a benefit claim, be it, in your case, the time to get a diagnosis. So each service has those service quality measures, and we report a lot of them in the annual report, which you'll have seen, and we measure the departments against those. I think it's fair to say, in my experience in the public service, which is a much more complex organisation than private sector organisations, in my experience, and much more multifaceted. It's fair to say that connection between discussions about efficiency gains and service qualities isn't quite as close or as axiomatic. I think that's fair to say is the case, but that's how we currently look at it.
Thank you. And you're absolutely right. Pure productivity, output divided by input, is a very clunky measure, and it's not appropriate for government. In which case, can you please let us know which peer-reviewed benchmark productivity trends, such as cost per islander for key services, exist, and what the trends have been over the last, say, 2 years?
No, I can't. I'll have to write back to you on that. I mean, the ones that we used in producing the CSP and that we've used in a variety of areas, the one that springs most to mind for me is the OECD Quality of Life Index data, which we choose to participate in, which gives us a benchmark to 447 other countries and nations. and that gives us a fairly extensive measure of different aspects of quality of life, and it breaks those down. So it allows us, for example, in areas like public safety, to have a set of comparative benchmarks that we can then apply to Jersey to understand the extent to which that part of island life, which is important to people, is the actual public safety, but also the perception of public safety. So that's one of the indexes that we would use, particularly at a strategic level in government. And it, as I say, gives us a comparative with 447. And we typically, and I'll send it along to you, but from the top of my head, we typically look at it across about 12 different categories of measures. That's one of the things which drives a lot of the benchmarking and policy thinking by the current housing minister when he's looking at housing affordability and availability issues in Jersey.
Okay, so those are outcomes that we're in. The question is specifically related to productivity and the costs of achieving those outcomes and what the trends are per unit islander. And I would appreciate any insights you are able to supply. I appreciate if you may have to do that. And within all of that, how do you isolate the costs of COVID, which has been mentioned extensively today? How do you isolate inflation so that you can actually identify just the core productivity gains of government? Because, I mean, the only way to achieve more with the same resources is to improve your productivity. So clearly this must be this must be at the forefront of your thinking.
Yeah, we try and express things in real terms, and even if we go back to what we were discussing earlier when we were talking about trying to break down the 13.5% increase in staff costs, you strip out inflation, you look at the areas where you have, if you like, permitted growth in headcount. Even within that, we're still looking for a year-on-year reduction. We're still looking for a productivity gain. So if you take that narrow example of health and education, where we did permit growth, the growth in 24 is round about 100 FTE less than the growth in 23. So to the Chief Minister's and the comms policy, we're not preventing absolute growth, but we're trying to curb the growth and curb the rate of growth is a big focus for us.
And how does that relate to the growth of the actual market, the number of people served, the number of students, the number of children?
Well, again, in healthcare, it depends which service, but in most areas of healthcare, we've got increasing demand for services, which a large part of which is rooted in the changing demography of the island. In education, to take a completely different exact, so the demography in the island is making productivity very difficult to achieve in health, as it's happening everywhere because it's ageing. You then go to the opposite end and say, well, if the demography is ageing, that must mean you've got declining cohorts of children. Therefore, you should be able to achieve significant productivity gains in education over the next 10 years in terms of number of schools, number of teachers, blah, blah, blah. So far, that has eluded us, and that has eluded us for a reason which I think is very important and is, again, one could argue, something that's been with us since COVID, is what we've seen is and measured is a very significant increase within each cohort of children, the number of children in that cohort presenting with additional needs who need additional support through education and care and health. So at the point now where we would be expecting with our accounting and economic brain to see efficiency gains, what we're seeing is that it's very difficult to get that money being released from a declining population of pupils dropping into the budget to be available for other uses, because the mix of need within that smaller cohort is changing, becoming more expensive, and that's something which at the moment is bedeviling some of the schools with their budgets, and it's something the Education Minister, I think, has drawn attention to recently after a Freedom of Information request.
Is that going to be a bulge that we will pass through, or is that structural?
That's a great question. I think it's there's no sort of consensus yet in the on the medical side or on the education side or in the research about whether this is a COVID-induced wave and it will settle down again, or whether actually we're in an era of enhanced diagnosis and change in the medical and care response to how people are presenting, which means that actually it's a structural change. But it's one of the biggest productivity issues we need to figure out for the education budget.
Thank you. You've mentioned the work done in restricting headcount growth. Can you give us an indication of what effect this has had on staff morale, please?
Well, we shall know better when we get the next set of results from our surveys on that. It hadn't had an appreciable impact in the autumn when we last did a survey, but the policy was in its infancy. I think obviously in some areas which are excluded, and Tom can speak for health, not seeing that so much, but definitely in some of the central functions, when we have our town halls and when we have our drop-in sessions and our leader sessions, definitely some colleagues are reporting that it's impacting. Then if the department feel that they should be filled, they will be filled. There are no real restrictions in there. Key vacancies around the place. Nothing stands out. We've got some departments who would like to recruit, which are subject to the freeze, where we've held them up. But we've held them up per the policy because we don't believe that they're fundamentally vital to the service, or that they can't be coped with through giving an existing colleague a chance. And this is a very, very big policy direction from the current SEB and Chief Minister, which is one of the things that they want to see happening in the freeze is if Department A has a vacancy and it believes it's vital, it fills that vacancy, then it should fill it by recruiting from within the service, or it should take this opportunity to put a development plan around someone and maybe give them a chance because they're only 55% ready rather than 75% ready. So we're seeing a lot of that happening, and we need to do a bit more to encourage that, because people naturally in Government of Jersey, it's still a lot of departmentalism. People naturally try and hold on to what they think are their best people.
Okay, thank you. And I had one more question, which was in relation to the moving on completely towards the £64 million capital underspend, which I believe was due mainly to deferral of expenditure, where capital projects had been authorised but not been commenced or undertaken. How much from the capital underspends will be allocated to the consolidated fund? The current disclosure is in the report simply says most, but I wondered whether you could give us some more clarity, please.
I can't give you clarity on the second part beyond that, but this underspend is completely dominated by one line item, which is new healthcare facilities. So at the start of 2024, we obviously had an interregnum because we had a change of government and a new health team come in, so everything slid to the right. And this is the thing that slid to the right, one of the things that slid to the right, the new healthcare facilities. So when you look at that 64, you know, the majority of it is the new healthcare
You don't
facility.
have an approximate number?
45 million was that alone.
45.
45 was that alone.
Right.
So yeah, so that
And that will
that's
go
what's-
to the consolidated fund?
I don't think that decision's been taken yet, but obviously if there are underspends through the year, that would be the normal course of action.
Okay.
We are between July and December 24 once we'd introduced that particular programme. So about 800 from those 7.
Thank you. And so I've got question 17 here, but I think we pretty much answered this one. It was about the increase, 13%, but I think we've spoken about that already.
So
just,
we
on this
finish
one, just on this one, very quick.
Sorry.
Are these permanently removed position or will be replaced?
Yeah, so what happens in those instances is, in order to be removed, we obviously have to go through a full business case and the normal consultation. So if the business case is approved and the role's removed, then the departmental budget's adjusted downwards so that the money's taken from the budget.
Okay. We've finished with annual reports and accounts, and we move to recommendations made by CNEG around arm's length organisation bodies.
In the previous quarter's hearing, concerns were raised about the absence of a clear framework to determine when an arm's length body should be established or not. Has any progress been made in developing such a framework?
No.
Is that- What role could the arm's length body oversight board play in developing such a framework?
I think a potential role, I think we have to decide first of all whether ministers think there's merit in investing the time and policy resource in developing the framework, but definitely that body with its terms of reference, what one would expect to play a role. In fact, it's I think as the committee are aware, it's a kind of strategic coordinating body, maybe not the sort of body that was envisaged when the chief executive of the day set it up. So I think this is the sort of area, if we went down this route, that would be right for that body to play a leading role in, and certainly for the chair to lead it.
Yeah, do you think they'd have enough resources and enough lead in that to actually make that work?
Yes, but it would need the prior decision, obviously, of it becoming a priority for ministers, and then it would need some additional support from the Cabinet Office in terms of policy support. But it's something I think they would be able to resource, and they would be able to do.
Because you mentioned this, that's really that you had concern about lack of guiding framework. Have you recommended to the Council of Ministers develop one?
I've not specifically said to them, you must do this, but I think this must have been comments relating to the speech I made at the Chamber of Commerce, and then maybe we spoke about it here. The bigger point I've been trying to make about all of these bodies, and there are days I wish I hadn't made it.
My question was, we'll go back. So basically my question was, have you put something in front of Council of Ministers that this is the framework that needs to be delivered to ensure that we are...
we're not at that stage yet. We're still at the stage in the context of this very tight fiscal situation that we're in, still having an ongoing debate about what are the next best actions if we have to try and find savings and take a savings-centric approach, if you like, to all the other things that we want to do. So we're still in discourse, I would say, rather than they've made a decision, because we're just not there yet.
So does that basically mean then there's no monitoring of the arm's length bodies?
Oh no, precisely the opposite. There's a whole framework that exists at the moment, but one of the major design issues with the framework and which has grown up organically because the era of ALOs it's a ministerial government era thing, the creation of so many bodies. So it's the last 20 years or so that I think we're particularly concerned about. The way that it works at the moment is there's a very established way of going about things. It's driven through the public finance manual. If a department thinks that they need to set up a new body, then the accountable officer and usually the minister concerned, they have to put up a business case explaining why, the wheres and whys of this, and how it will be funded, because typically it will be funded from their departmental budget. If that gets approved, then the way the public finance manual works is it doesn't vest the control and authority in the board. it vests it in the accountable officer through the Public Finance Manual. So when it comes to reviewing that organisation, agreeing its letters of instruction or its annual memorandum, assessing its performance, it's all driven down to the accountable officer on the department level, and the board, if you like, has got a much more coordinating best practice role, where it does some great work. But at the moment there is a framework. I was just suggesting that we could maybe enhance the Public Finance Manual current approach with a clearer actual overarching policy framework for deciding when and how you intervene and whether it's worth it and how you evaluate that. Rather than business case by business case.
Yeah, so with that being said, has there been any strategic reviews taking place in 24 with any of these bodies, or indeed is there anything planned for 2025?
None I'm aware of in 24, and none I'm aware of in 25. And if you look at the CSP and look at the government's priorities, it's not in there, therefore it's not in my objectives either.
So I'm just seeing if I've got anything else.
It's interesting, yeah, that from one side, and we agree that we have too many of them, and we need to see how they really deliver value for money, and we need to see if there actually needs this amount of ALOs needs to be there. This was your views. At the same time, you say it's not on your objectives. So how you raise your concerns, because you're principal accountable officer and said we need to save the money, we need to see how the value for money delivered. This is your role. You're raising it with the Council of Ministers and advising the Council of Ministers maybe where the money can be spent differently.
And to be fair, you encourage you put me in a position of saying my advice is not always taken, and of course that is correct. But
the advice could be there. They might be not taken, but the first one, it's advice.
I think there's two parts to this. I don't want to narrow it because there are all these different definitions, and I've already fallen into that quagmire. But any body that we've created or that we fund in this whole complex estate, I was trying to make 2 points. The first one is a narrow one, is if we're going to have a very tight public finances position, which we have, if we're going to look closely at our spending envelope, my first point to all islanders is to say I think it's legitimate and reasonable that that scope includes all of these bodies, not just the usual suspects at the centre of government. That was my first point. My second point, which I was trying to make, maybe not with as much success, is the thing I'm very concerned about is what in the British civil service, but I now think everywhere, is known as Parkinson's law. Heathcote Parkinson's famous article, and essentially Parkinson was worried that that particularly in public service, if you have more seniors, they hire subordinates, they don't hire rivals, so you get a sort of steady spread. And when you create so many chief executives and so forth across all these bodies, they will hire subordinates and you will get growth. Some of that might be desirable, some of it not. But the second point of Parkinson's law, which is vital, which is the one I was really trying to make, was they then create work because they create work for each other. So you then create this infrastructure where you're actually talking to each other and generating work between this agency and that agency and this work. And that in itself leads to a kind of growth which usually has a problematic relationship with productivity and effectiveness. And that's what Parkinson was calling out. And that's really what I'm calling out in the complexity of governance in Jersey. I just think that between all the different things we've created, for good reasons or not, actually trying to run it now, it's beset by Parkinson's law. And I'm just worried that we're spending too much money within the system talking to each other and not enough money on what really matters to islanders, which isn't me talking to Tom.
Which is raising question, but by the way, I completely agree with this view. I think I can see the committee members also feel the same. Now the question from the committee, what are the steps that can you take to address this?
Yeah, so in that context, it's still very much, obviously, it's a live debate in the context of curbing the policy to try and curb the growth in the public service. Number one. Number two, as we workshop our way through the budget challenges, which we're doing, as we workshop our way through things like health, which we're doing, it's feeding that advice and those options into ministers to give them different ideas of how they might start to address this very tight fiscal position. Not just for the ministers here at the moment, hopefully, you know, for ministers for some years to come, because this would be a multi-year endeavour. So it's very much, the first thing was to hopefully diplomatically call the issue out. The second thing was to raise awareness and get it into the discourse, which we're having today and we've had in various forums. And the third thing is to see that if it creates a momentum, if there's a policy coalition that says, actually, this is one of the things we do want to change, because there are various options. You don't have to do that. You can do other things. So that's what I was trying to get it to do. And I think when you think about how much money it would save you, it's not enormous sums, it's appreciable sums. I'm more concerned about the second part of Parkinson's law, which is gumming up the
You
system.
have duplications in the system.
It creates implementation problems. It's hard to get stuff done because you've got a triumph of process over outcome because you get so many people in the process, if that makes sense. That's what and this work started actually under the previous government, I should say. It's been going on for a while.
On the essence of this, doesn't this then highlight the urgency of reviewing all these ALOs to see where you have duplication and see where there is ground for consolidating and saving in that sense?
Yeah, I think in these areas, as the committee knows, there isn't a political consensus on this. There is an aggregate that maybe something should be done, but everyone's got their favourite body. But I think it's fair to say that in this area, you know, we are in a lot of sympathy with the CNAG's advice to us.
I'll move on, but we'll get back because, as you know, we're doing
Sorry,
ALO's
yes.
review, and obviously we'll come back to you with to have more details. Now, one of the actions, and I know it's due to Q4 2025, but it's important. What progress has been made in development of cross-government commissioning and partnership strategy?
Okay, so we're not just in health, but in general. So
Yep.
yeah, so we the cross-government commissioning group has been established and begun its work. It's developing a strategy which we hope will be ready at the end of this year, in part because that strategy is very important to some of the decisions I think we're going to face in health and in children's services and education, but particularly in the children's services part of education. So the strategy is under development. I had a session with them, I'm going to say about a month ago, on the strategy, on the options that they're developing and some of the risk assessment that they wish to take. So they are knee deep in their work. I think they're working well as a group. They've already taken some important steps. They've produced a toolkit around commissioning and partnership, for example, a more standardised, rationalised approach to partnerships agreement.
Who is leading this work?
The ALBO's now led by Paul Wiley. It was you, I guess it's Paul Wiley.
So he's the officer.
What's the name of the colleague who's leading the
Commissioning.
Yeah.
Emma Paul Hill in
From strategic,
from health.
from health.
Yeah.
Okay, and has stakeholders...
So they're up and running anyway to answer
Yeah.
your question, and they're developing a strategy which we're trying to sync with, amongst other things, the work that's going on in health in terms of the big debate that
What
should
risk
happen.
could delays the delivery of the strategy by Q4 2025?
Well, at the moment, I'm not aware of any. In other words, I only saw them
Okay.
last month and they're on track, so unless there's new information.
Not aware of any delays?
Okay.
And equally, a governance committee was to be in place by end of 2024. Has the Off Island Tertiary Governance Committee been established?
Yeah, that's up and running, and that started last August.
Yeah.
And
That
what,
meets monthly, yeah.
what are its functions and how is being monitored?
Well, I've got a terms of reference for it.
We can ask it.
can
right?
receive
Yeah.
it, yeah.
If you, do you want me to send that along to you? Yeah, I've got a.
Has it shown any early results?
I think in terms of dealing with the challenge I mentioned earlier about how do we, it's not fair to say enforceability of the framework agreement, but how do we ensure that the spirit of the framework agreement with NHS England is respected? And I say that gently because I'm well aware that NHS trusts are under enormous pressures themselves, so this is not an easy business. So in areas like this, I think they're starting to make good progress. They have got their teeth into reviewing the 50 arrangements that we've got in place in England, which I think we all agree this is the 50 arrangements we've got with different hospital groups in England for tertiary care. I think we all agree that that's something that's developed organically over several decades, sometimes based on relationships between medical practices, or a doctor might have developed a relationship with a medical practice in the UK. All good reasons why it looks the way it looks, but we've really asked them, given the situation we're in, to look at how that could potentially be rationalised and be made more effective going forward. So that's the sort of work that they're currently engaged in, which will certainly help us with the budget, but as importantly, I think it's crucial work in trying to help define the big building blocks of the future healthcare strategy, because whatever we do, we know that we'll always be in a position where we have to procure from off-island and send people off-island.
So has a review been conducted into the off-island tertiary contracts? And if so, what were the outcomes?
Do you want to give a bit more detail on that?
Sure. So we've started to work our way through all of the different tertiary arrangements. Some of those tertiary arrangements are valued by clinicians, valued by patients, very important, and really we just need to ensure that we're getting best value out of them, but continue. Others perhaps less so, perhaps less valued, in terms of the relationship, the quality that the patients receive, and so we're looking to see what we can do over time to change the arrangements, and in particular to consolidate more of them together, because obviously if we can consolidate some of those arrangements, then we can develop more of a relationship, because a lot of the current interactions with tertiary centres, I think, would be characterised as being quite transactional. Kind of a patient gets referred, we pay a bill. It's got a transactional relationship, whereas the relationship with some other tertiary centres is much deeper. Our clinics are working in multidisciplinary teams with those centres. They're perhaps visiting professors as well. We're getting all sorts of staff development and extra benefits from having a proper kind of deeper relationship. So the direction of travel is to see where we can work our way through the 50 so that what we end up with are the relationships that we really value, the clinicians value, the patients value, and also the relationships where we can get more value out of the actual organisation to organisation work, whether that's staff development, whether it's R&D, whether it's multidisciplinary learning and working. So that process is underway. The creation of the group has been really, really helpful in kicking that off and enabling us to work with clinical colleagues and with others to start to address that. So we're underway.
And are any new arrangements that are in place based on those reviews?
Well, tertiary work does move around all the time, so it's never exactly the same 50. So at the moment, we're looking at new arrangements in a couple of areas. That's normal. In any one year, they move around. So for me, it's not so much the moving around and, you know, new arrangements come and go. It's about how we can develop, you know, a more strategic partnership with 3 or 4 at most centres based around needs. So as you know, we have quite a significant relationship with Southampton. Southampton's one of the biggest providers in monetary and volume terms. So we're seeing how we can deepen our working with them to get more benefits for Jersey and them. But I think for me, the test is whether we can get into a much deeper kind of partnership arrangement with a smaller
How do
number
the
of centres.
performance of old and new arrangements would be ongoing monitored?
So we have different ways in which we look at the performance of a tertiary centre. So on the one hand, there's a kind of a financial value for money assessment on behalf of the taxpayer. Are we paying the amount that we want? Are we getting good value for the Jersey taxpayer out of that aspect of the care? We also look at it in terms of clinical outcomes. Have the patients got the treatment that they wanted? Are we getting good benchmarkable clinical outcomes? Are we getting good results for patients? So we have lots of different ways in which we look at how they're performing.
Okay.
And then obviously we look at some more closely than others. And when you've got 50, some of which are really perhaps only used for a handful of patients each year, they don't get the same close examination as, say, Southampton, which is why really we're looking to develop a much more strategic approach to this, because then, with the fewer centres delivering more for us, then we can get a much more rounded view of how they're performing.
Tom,
Thank you.
sorry,
We'll
can I
analyse
just
this
ask
more
a
in depth
question?
and we move.
Sorry, just might be my naivety, but when I hear this, we're just focusing on the UK. What is there any reason why we don't look further afield? Especially when I look out my window, I can see France. So I'm wondering why we don't have those sort of agreements in place for something that's closer. That maybe that be a cheaper option and start setting up more than just our eggs in one basket.
And I think that comes back to the point that the Chief Exec was making about how the 50 or so arrangements have come into being.
Yeah.
And most of them have come into being over many decades, usually as a result of relationships between clinicians. And so because most of our clinicians, are coming to us through, a British medical training route, they've got connections back with, where they trained in the UK with those centres. So they're reflecting decades of individual relationships and
Might not
associations.
necessarily be the best.
Yeah, it's
Absolutely.
It's a great question. And one of my sort of hopefully constructive challenges to the tertiary group is if you look what's happening in the private market, people go to many places for their healthcare. Now, obviously, people's budgets are different if they've got private health insurance, but they don't restrict themselves to the UK. They typically go to the UK, but they don't restrict themselves. I think as Philip and the team explained it to me, when you move from the individual with insurance policy to system, clearly we've got responsibilities around some of our standards that we've adopted, which are typically relatable to the UK NHS for all the obvious reasons. And we've got issues around language. We've got different issues that we have to think about, but it shouldn't stop us thinking about them. I just wanted to mention one thing in response to your question, because one of the things that you have introduced, which I think is important, is, and it is a bit of a control mechanism, is effectively the tertiary referral panel, which is a weekly panel, which is just trying to put more governance around the oversight of the referrals and whether we can intervene at that level to make sure that we've considered the most cost-effective or appropriate alternatives. I think we had a system before the recovery group were effectively put in, where it was probably a bit more organic and I wouldn't say casual, but certainly we didn't have the level of oversight over it pre-COVID that we would have now. So these steps are being taken, which I think are useful steps to take, and it's partly in a response to the fact that the budget is proving difficult. Yeah.
Yeah.
If I may,
Yeah,
sorry,
sure,
in
absolutely.
line with Glenn's question as well, and the patient experience of their engagement.
Yeah.
Transportation appears to be a thing that's really impacting upon the patient experience, and I would imagine would have an impact on their clinical outcomes also. So what considerations are being given to those contracts with tertiary centres and our ability to get patients there speedily and with assurance that they will make travel on the day that they expect to?
Yeah, when we're looking at our criteria for, you know, which tertiary centres we seek to develop a deeper relationship with, one of the criteria is the travel links. You know, the kind of all year round travel links, because that's absolutely essential.
Thank you. So we're going to now just have a brief period looking back at the Controller and Auditor General's recommendations with regard Health and Care Jersey's staff resources. So we note that the delivery of those meeting those recommendations has been put back by some time to the end of this year now. So what has caused the 2-year delay in implementing those recommendations, please? Particularly, we wanted to look at recommendations 2, 3 and 4, which are around staffing and workforce models.
Do you want me to start, Tom? Or
Yeah.
So I think, again, thank you for the question. It's a mixed, I'd say it's a mixed picture in terms of meeting the recommendations, which you're calling out. Obviously, 9 or 10 of them have been addressed and were able to be addressed quite quickly. I think those which are still outstanding after 2 years, there's 2 things to say about them. Some of them, I think, quite properly take longer and don't lend themselves to a quick closure. Doesn't mean to say lots of stuff's not happening in the meantime, because they're progressing. But also, I think it's fair to say that during this period we have had the interregnum of a complete change in the ministerial team in this area, and we have got the ministerial desire to bring to the Assembly essentially a new strategy and model for healthcare provision. So if you take, I think that the first one that you asked about in recommendation 2, but I guess it applies to the first couple, to us it makes a lot of sense that the work that we do on those recommendations pays attention to the wider work that's happening in terms of healthcare policy within the government. And certainly when it comes to workforce planning, it would be, and the CNAG I think has acknowledged this, it would be an odd situation if we developed a workforce strategy before we developed the strategy. So we're trying to get the 2 things in sync, but a lot of work on workforce strategy has taken place during that period. In other words, across 12 now, I think, discrete departments in health, we've had those deep consultations with colleagues about workforce strategy. So a lot of preparatory work's been going on over those 2 years, but we're trying to make sure that the 2 things actually speak to each other come the end of this year.
Identify a lot of this is officer driven, such as delivering on job planning and
and I think this year I will find the latest statistics in a moment, but you know, it's going well. I think we're more advanced than we have been in any other year that I can recall. So I mean, we're well over kind of 75-80% of the way there. So I'm feeling quite positive about job planning.
that's very good to hear. Thank you. And of course, we fully appreciate the issues that have occurred over the last year and a bit. But do you believe that in the current scenario, the target dates for meeting those recommendations will now be met?
Certainly for the everything around the workforce strategy and workforce planning, yeah, I think we're in good shape. We've had, I think, all of the big strategic workforce planning workshops now, whether there's any outstanding. So yeah, I think that work's on track for December 25, and obviously will be an important almost compendium or linchpin to the wider discussion in the Assembly about how we deal with this issue of what we hope to deliver for islanders with the affordability pressures that come with that.
Yes, well, indeed. Do you have an ability to quantify the impact on both cost and health outcomes of not moving forward and progressing with those recommendations?
Original completion date was 30th of June 2023. New completion day now 25, 2 years later. So we're thinking about latest reports that were released about the quality of the services. We're talking about rheumatology, maternity, orthopedic, and I think there are several more reports were released over the last year, which question in the clinical standards. So, for example, if recommendation 15, which asking urgently implement supervision, would be implemented, would the reports look differently?
Yeah, I understand the question, and this is almost closed, this one. I just don't know if I can give a good answer, because if you think about it, if you take an example of a clinician, to keep this example going, there is an assessment when they arrive. There's obviously an assessment through recruitment. There's an assessment when they arrive. They have got very significant obligations to the General Medical Council as part of their own professional commitment. So it's not a blank sheet. So the question is, will we get a significant cost or quality improvement from the final step? We think the final step is very good practice. Whether we could look back and say if we'd had that in place, there'd be some big gain over the past 2 years.
I understand.
That's what I'm struggling with.
But
I'll think about it.
But I think that when Synergy said urgently, and we're talking about clinical supervision, and it has been accepted and it should be delivered 2 years ago. But now, let's move on. Let's look in the future.
But
Has it been delivered? Would it be delivered in June 25?
Yes.
Yes. What the cost or funds have this wouldn't, because clinical supervision will require extra funding. So what's the forecast that you input in 2025 budget for health to implement this policy?
The policy doesn't, to my knowledge, require additional funding. We have a number of clinical policies in the department to do with the way that
just a minute.
doctors work, nursing work, but we don't.
So clinical supervision would require consultant, supervisor, for example,
That's a
supervisor
requirement
time.
already.
That's already there.
That's there.
That's my point.
They're already supervised.
But-
The recommendation was that we have a policy that codifies that supervision, and that's what's now coming into place. But you can't work without the supervision that's required under your GMC registration.
Yes, but the supervision would be require different time. When you have a policy, it would require more resources from the consultants to follow the policy, unless you basically created something that was in the first place.
So the policy essentially codifies best practice, and so you would of course wish that best practice in the past always happened, but the policy codifies good practice in clinical supervision. But the requirement for clinical supervision exists today. The requirement itself doesn't change. What changes is that the policy codifies, really good
What's
practice
changed in
in doing
practice?
that.
So
Well, I think there's two parts to this. I think I understand the question better now. Obviously, we have historic and recent situations where supervision may not have been what we wanted it to be, and that's working its way through. But I think when Deputy Moore brought in the hospital turnaround team, obviously a part of that was finance, but a big part of it also the remit, arguably the biggest part was governance. So Tom's predecessor and various colleagues had already been working on ensuring that what we would regard as best practice, what the GMs, the General Medical Council would expect and so forth, was actually happening in our hospital. The step that we're now taking, they did a lot of work on that from a governance perspective, the step we're now taking is, if you like, documenting that and having the policy which hopefully reflects the improvements that have been made. So I don't want people to get the impression it will fundamentally change what's happening. Hopefully it will codify what should always have been happening. Is that the best way to... Does that make sense?
That takes us back to the question, why has it
Okay,
taken
fine.
2 years? If you're already doing it.
Find the process.
It is.
Well, it took 2 years, yeah.
It's a
Yeah.
policy that should be good supervision. It's just it's codifying what that good supervision means.
It is.
Even though you're already doing it, it's now actually written down. That's what you're saying.
That's what we're saying. And to answer to other question is, there's a lot been going on in health. There was a lot for that turnaround team to fix, if you like, and they're prioritising they were prioritising, especially in 2023, early 24, prioritising a lot. The first most important thing was to give more confidence and governance around whether clinical supervision was happening in the way that we'd all expect. Now they're getting to documenting that. So that's the...
We'll go to Ali.
Yes,
Thank you.
So moving on, can you just let us know about the current status of the agency contract for the locum staff? And leading into that, the cost has increased there as well. So can you just let us know what's making that change and why we are not forecasted that if it's inflation we could have? And lastly, what's the price point we are aiming in acquiring those staff members?
So we're currently towards the end of the current contract period with our main provider, and so we're just starting the process now of how we go back to market and test whether we can achieve the kind of value that we want out of the providers who are in the market. So we're towards the end of towards the end of a contract period, and just about to start the market testing that for the next period. In terms of price point, I guess the main thing to know is that if you're filling a full-time, hard to fill medical role with an agency kind of doctor, you can be paying kind of up to twice the rate that you might pay for an employee.
And on the forecasting point, like we've seen the increase in cost in the last year, how we are incorporating that in the future forecast and how we can improve that.
Well, as Chief Exec mentioned earlier, there was good progress made last year on the nursing side. Yeah. So there was a heavy dependency coming out of COVID on agency nursing, and now there's a really good cohort of permanent nursing staff and very little use of agency in comparison to where we were a couple of years ago. So that has progressed, mainly because the market still provides people who want to work permanently in Jersey as nurses, which is great. So it's with effort, with focus, with some good campaigns, we've been able to fill permanent vacancies. The focus this year is on the medical vacancies, so the doctor vacancies. A lot of those are in specialities which are very difficult to recruit into across not just the British Isles, but often across the kind of the West at the moment. They're in areas where most of the people working in that area have signed up with agencies, because it gives them more control, it gives them more choice. They're at a premium. Now, doesn't mean that we've given up. So for
We're
example,
not giving up, but we're having less success with
We
doctors
are.
and nurses. That's what we
so for example, there are, around 23, perhaps 24, long-term kind of doctor posts which we're having to fill through with agency colleagues. Those colleagues are great, they're doing a great job, very valuable, good members of the team. But obviously, if we can fill some of those. So having looked at it and having looked at the market, our goal for this year is to see if we can fill half of those, with permanent staff. If we do, we'll have done really well. We'll have probably outperformed the market, in terms of what it would achieve. But that's where we're focusing this year.
I think this goes back to what we were just talking about earlier, that there's a feedback loop from this to the strategy, which is, have you got a model that you find it very difficult to staff? And therefore, have you got are there any alternatives? Obviously, we've got a scale economy issue. We've got a statistically relevant population of 100,000 people, so we'll have at least one of everything. So how do we then arrange ourselves as efficiently as we can to address these issues? And the challenge we've got in some of these posts is the market has become like the IT market 30 years ago. People realise that they can make more money and have more freedom if they're a contractor than if they tie themselves as an employee. And we've got the additional challenge in Jersey, I think, of trying to create a nexus between their employment and their residency that's attractive to them. So those are the things that we're wrestling with. And as I say, they seem like almost tactical issues, but actually they're telling us something about the workforce plan, and they're telling us something about the strategy for healthcare and for the island, because we're finding it really difficult to recruit.
I'm minded about the time, and I
sorry,
just
yeah.
would like to check, would you have another 10 minutes or you need to go sharp at 3:30? I'm just checking.
I think we have another 10 minutes.
10 minutes.
If we can do a deal that will mean less questions and writing after.
It would be, it would be a deal, because it will be less written questions, obviously.
Let's go for that deal.
Very succinct answers.
Can I just continue on this? On what is then your strategy, your thoughts on what measures have to be taken to reduce the reliance on locum?
So that's where, as Andrew's outlined before, one of the reasons for wanting to do the workforce strategy alongside the other work is one of the important pieces of work is the clinical strategy.
Yeah.
So, we have, not just the whole island health and care strategy, but the clinical strategy. It's really important because, that will then set out our shared thinking on where we're going with the provision of, all sorts of clinical services on and off island that will then inform, where we need to go on the workforce. Mm-hmm. But doing those two things in parallel is absolutely essential, because it's be no use us developing a clinical strategy that we can't staff, or a staffing, strategy which gives us staff that don't fit the clinical strategy.
It needs to be
they
developed
have to
together.
work
It's
together.
a
Yeah.
big issue, and it's one that the ministerial team are wrestling with, is it's oftentimes not oftentimes not a cost saving between filling the post and delivering on island and sending off island. In other words, it's not necessarily cheaper. So the issue is often not just about money, it's also about sustainability. It's about saying, yes, it's not cheaper, but if we send it off island, then all of the sort of issues around the workforce plan, the equipment, the staffing, everything sits with that supplier, and we're in a different relationship. Whereas we're doing it on island, we might not have a cost saving, but we might have these real challenges of being able to recruit people constantly and all the rest of it. So there's a lot of judgment calls from the clinical strategy driving what's actually the best way to deliver the service for a given amount of money. And that's what we need to work our way through and that's ultimately what has to be debated, because that will then shape what the service looks like going forward.
We
What's
have last
credible.
couple of questions. You would like to last couple
Yeah.
of one more question, and after we'll go to Philip and we'll
Yeah.
wrap up.
Just on the locum staff, are their staff still engaged with our clinical supervision? Like, how their contracts been updated?
With clinical supervision.
Yes, yes. So they now, locum staff go through an induction programme on arrival that outlines our requirements and expectations on clinical supervision.
And there's any anticipated costs to this change?
Change has already been implemented and
It's already been implemented, it's there.
In the budget.
Yeah.
And are there, like, due to this supervision thing coming in, have you seen the change in overall, like the shortness on their practices and everything? Has there been change noted on the locum staff after the clinical supervisions have been?
I think one of the things when you're looking at our use of locum staff is they're quite a broad church of different sorts of locums. So some locum staff maybe are just here for a week or two to cover a doctor's period of leave, so that the clinic is still staffed and can keep going. So they might only be with us for 2 or 3 weeks in a year. And then the rest of the time they're with another hospital, usually in the UK. Other locums are effectively, at the moment, forming part of the permanent team. And so they just run alongside the permanent team in a completely integrated way. So they're not all the same. They're not all doing the
Got
same
it.
thing at the
So,
same time.
thank you.
Yeah.
Just sticking with the workforce and resourcing issues for the moment, since you've been in post, have you continued the work that your predecessor was doing with Guernsey to look at how those resourcing issues can be overcome by working jointly?
And in fact, we've expanded it. So we did indeed keep going with the work with counterparts in Guernsey. So we have a regular cycle of discussions and dialogue, really positive, incredibly helpful. And then a week or so ago, we held the first of a slightly broader forum where I also invited counterparts from the Isle of Man and from Gibraltar as well. And the four of us, coming together to look at shared challenges. And that's really helpful because that helps us get into, where it might be we've got a local issue where we can solve some of that through financial controls. And they've learned how to control an expenditure in a way that then we can learn from. So we're doing that at the moment with the Isle of Man, who have done lots of good work on their UK tertiary costs, and we've been able
And
to
Gibraltar,
learn.
I think, the relationship they've
Yeah.
got with.
Yeah.
But that's
Yeah,
still in
the
the
London Trust,
discussion stage rather than physically being able to define where you can share resources to reduce costs to each jurisdiction.
Yes, I mean what we've been doing primarily over the last few months is focusing on exchanging expertise, knowledge,
Not delivery. Okay.
comparisons, so that we're able to learn fast and implement in our own jurisdictions from what other people are doing. And that's really
No,
been the
thank
focus.
you. No, next.
Okay,
Yep.
I'll ask two questions in one. I want a succinct answer. The private patients plan was published in May 2024. How's it going? And have you done any reviews to determine whether or not it's meeting its objectives and how effective it is? Succinct.
Yes, we do. Ultimately, its test of success is measured in the trend in private patient income. So, that's gone from 10 million in 2023 to 12.5 million last year, and this year we're forecasting 14 million.
Even though there are pressures on that, as the chief executive
So the
already
original-
said.
He hasn't said that
So
misses
the-
budget, he's just said it's higher, but yeah.
So we originally wanted to achieve more than 14 million this year.
Yeah.
But as the chief exec mentioned, in order to deal with what were quite extreme winter pressures, then we had to surge into the beds that otherwise would have been available for private elective care.
Okay, thank you. I've asked my question.
Yes, I'm just checking with the committee on statutory plan. Is any more?
Just very quickly on that last point, have you passed on all of the cost inflation through to private patients per procedure, for example?
We have now.
Have now? Could you
Have
give
now,
us more-
women now is?
As in, it's taken a few changes to our tariff rates for the different insurers to catch up with real terms inflation. So we've done a series of changes every 6 months or so over the last kind of year and a half, and that's now caught us up.
Okay, great, thank you.
Ali?
There is a full update going to the Healthcare Board in July, which I guess will that be publicly available?
Yes.
It will be, yes.
Okay, thank you very much. We would have some written question, but less. Thank you for extra 10 minutes. Thank you for your time and public hearing.